My name is Joan Udejiafo, and the title of my presentation is Diabetes Education for the Elderly. Diabetes is a chronic disease characterized by high blood glucose levels. High blood glucose may result from inability of the body in producing insulin from the pancreas or insulin not working properly in the body. Type 1 diabetes is caused by insulin deficiency, and type 2 is caused by lack of insulin or insulin resistance. Insulin is a hormone produced by the pancreas. It is needed to move glucose from the bloodstream into cells for energy. Lack of insulin or resistance of cells to its action leads to high blood glucose levels. Diabetes is one of the most chronic illnesses that affects the elderly population. According to the CDC, 26% of Americans aged 65 years and above have the disease. The prevalence is expected to increase in the next 20 years. There is a statistic that states that for every 10 healthcare dollar, $1 is allocated to diabetes and its management. Who are the elderly? The young old are characterized as persons aged 65 years to 75 years. The old are persons characterized from ages 75 years and above. Diabetes is usually undiagnosed in this population. The elderly population is characterized by cognitive and physical impairments. Also, geriatric symptoms exist within this population, which include polypharmacy, pain, and depression. Another issue is finances. A complete diabetic assessment must be obtained before diabetic education teaching, and it should include a physical assessment, neurologic assessment, psychosocial assessment, and other spheres of living. The physical assessment should include an ophthalmic, auditory, renal, and immune system. We should assess for cataracts, renal insufficiency, herpes, flu, cardiovascular risks such as CVAs, MIs, mobility and physical activity, evidence of joint disease, assessment of activity level, nutritional status, hydration status, alcohol use, substance abuse, gastrointestinal issues, appetite, gastroparesis, nutritional assessment, oral care, meal preparations, neurologic assessment, mental diagnostic to determine the presence of cognitive impairment, dementia, depression, peripheral and autonomic neuropathy. Autonomic neuropathy will lead to hypoglycemic unawareness. Peripheral neuropathy could lead to the presence of an existence of foot ulcers. Psychosocial assessment should include depression, support system, locus of control, health beliefs, and should I also add culture. Some diabetic education topics can include glycemic control, hyperglycemia and hypoglycemia, hypertension, nutrition, a couple of screenings, nephropathy screening, retinopathy screening, food screening, physical activity, lipid profile, aspirin use, tobacco cessation. Diabetic teaching is usually based on a number of learning theories, and the theory selected here is Knowles' theory. Knowles popularized the concept of andragogy, which is the art and science of helping adults learn. His theory is based on a number of assumptions. 1. Self-concept. 2. Experience of the learner. Readiness to learn. Orientation. Motivation, and the fact that adults need to learn they exhibit a willingness to learn. Characteristics of a diabetes educational plan. Functionality is one, which means that a plan should consist of goals which are measurable, valid, and action-based. It should be flexible. It must take into account the ever-changing needs of the elderly individual and should be open to change. It should be realistic. The plan should be practical, scientific in the sense that it should be evidence-based in terms of knowledge and behaviors gained. Economic, the implementation portion of the educational plan should be affordable. Goals and objectives can be developed for individuals in the cognitive, affective, and psychomotor domains. In the cognitive domain, an example of an objective will be that after teaching, patient will know what normal blood glucose levels are. In the affective domain, an objective will be that after teaching, they will believe in the importance of measuring blood glucose levels at higher intervals. In the psychomotor domain, an objective will be that after teaching, the patient will measure blood sugar levels by him or herself. The use of diabetic teaching aids should be adapted for this population. Fonts should be large enough. Use images and graphics wherever possible. Use words or posters rather than long paragraphs. Avoid medical terminology. Develop cultural, linguistic, sensitive, appropriate teaching materials. This is an example of an educational material which has been adapted for the elderly population. Note here that it is better to avoid long lengthy sentences and to make use of graphics and pictures. Other strategies include auditory accommodations, which will mean speaking in slow, short sentences, minimizing background noises. Cognitive accommodation, simple instructions, focusing on one single topic at a time, making use of memory aids. Educational aids, use pictures, images, posters wherever possible. The success of any educational program is usually in terms of achieved objectives in the different domains. We can use quantitative in terms of post-tests and qualitative in terms of observation and interviews for evaluation. Whichever way, what we need to assess are what has been accomplished after the training. Has there been a change in attitude, such as the patient verbalizing willingness to accept their new diet? Or are they able now to test their blood sugar given a glucometer? Both types of evaluations may also be used together to offset the individual limitation. Thank you very much for listening to this presentation.